Hey there. So today's video is being brought to you from the beautiful Royston Beach. So I'm going to attempt to do this video here and hope that a wet dog doesn't come and slobber all over my video. But we'll see. I wanted to talk to you about the changes in hormones that happen through our reproductive lives and a little bit of a basis of the menstrual cycle and the changes that happen around menopause and perimenopause, with a little bit on the different types of hysterectomy and what the consequences of those might be. But before I do that, I want to just do a little segue about medical evidence. So it's kind of struck me over the years as I've learned more and more from my patients, from my reading, from my own experience with menopause, that there is a massive, massive gap in the evidence and research that we actually need to do this job and treat this transition properly. And if you think about it, the vast majority of medical evidence is funded by pharmaceutical companies. Research is enormously expensive, and there has to be a financial path. So unfortunately, what that means is there's a tremendous amount of bias in medical research, and you don't have to dig very far on Google to find unethical pharmaceutical companies hiding side effects of drugs, pushing drugs really hard before they've been actually approved, in a really systematic way for profit. The one that comes to my mind is for Bristol, but that's a whole other story. What we're basically doing is studying people with problems to see what pharmaceutical intervention might help their symptoms. Like, take mental health, for example. A lot of those drugs treat symptoms, but we don't know the underlying cause of the symptoms, and the side effects often cause other symptoms which are managed with other drugs. And as far as I know, there's not a lot of medical research researching well people or dietary intervention or those sorts of things, because nobody makes money. And so I think we need to realize that that is a whole complicated system that is probably not going to change substantially. But we do need to understand, when we hang our hat entirely on medical evidence, we have to ask, are we even asking the right questions? The evidence that you get is only as good as the questions you're asking and the population you're studying. And there's usually so many variables that you've got to question, even if the results are translatable to other people. So it becomes very complicated, and I like the expression, the best evidence is the evidence we have. And sometimes in medicine, we get very tripped up with forgetting that you don't know what you don't know. And curiosity and innovation can get replaced with dogmatism very quickly. And it's sometimes very difficult to get people to change their minds in the face of new evidence. And that's exactly what scientists are supposed to do. Not get clingy to their beliefs, but to actually change their mind in the face of new and compelling evidence. The problem being, of course, that the research that we actually need to have done is likely never to get done, because who's going to pay for it? So women are kind of stuck with the best we have. And honestly, I believe, this is just my opinion, but I believe that a lot of the menopause guidelines are focused on sick care. They're focused on only alleviating symptoms and ignoring the vast majority of menopausal symptoms, and prevention of disease or outcome of disease. Like, it's not, can hormones prevent this, as much as do hormones cause this? And if there's even a tiny association, then we claw back access for women to HRT. And I think I said this in one of my previous videos. If you Google the side effects, risks, and complications of so many pharmaceutical products that are prescribed regularly, and then compare them to the risks of hormone replacement therapy, it'll leave you wondering why women are told this is so risky, and other stuff is like we just turned a blind eye to risk. And I honestly think there is a huge industry-driven bias amongst physicians while we're telling ourselves that we are critical thinkers and that we analyze the research. But sometimes when you're so close to the fire or so deep in the woods, you can't see the forest for the trees, you know? And so I like the whole concept of zooming out. Now, here's the other aspect. When physicians ignore the mind-body connection, they don't associate mental health symptoms with hormonal imbalance, and those things are dismissed, there opens up a whole avenue of care that gets filled by naturopaths and other alternative practitioners. Now, I value collaborative relationships with the naturopaths in my community, and I plan to work to build them, because I think the thing is, a lot of physicians are very critical of how naturopaths practice, but at the same time, they're addressing a lot of the needs of patients that we are ignoring. So like always, the answer lies in the middle. We have to collaborate, share knowledge, share approaches, share perspectives, consider each other. And I think that there's some real hope in that sort of collaborative practice. However, there's also a whack ton of people selling garbage for lots of money with empty promises about how it's going to alleviate all of your menopausal symptoms and you don't have to take those cancer-causing hormones. And unfortunately, there is a huge population of women going through menopause who don't know what the hell is happening with their bodies and are desperate for answers and are not getting them from primary care. And do you blame them for seeking them in other areas? Of course not. The answer isn't that physicians need to do it all. The answer is there needs to be some collaboration and a little bit of kind of opening our mind to alternative options. And like Tim Minchin said in one of his songs, you just don't want to open your mind so wide that your brain falls out, like there's a limit. So having said all of that, I really think that where the power lies is in if as women, we understood how our bodies worked, we learned to listen to our bodies and trust our instincts and know where the pitfalls are and what some of the research shows, then we are much better captains at being able to navigate our own menopause ship and not take dismissal and advocate for ourselves and search for the right answers for us. And that's not happening enough. And so that's kind of one of the purposes of today's video, is I'm hoping to give you a bit of an overview of your hormones. And so let's get started. I tried to draw a picture, okay? And videography is not one of my skills, neither is drawing, but I figured this would help if we had a little bit of a visual. Okay, so this is my attempt at drawing a uterus. Okay, so basic anatomy, okay? So here we have, this is the uterus itself, with the pink being the myometrium, which is the muscular part of the uterus right here. This is the part that contracts when you're in labor. It's also the part that contracts during your period and causes menstrual cramping, okay? The green in the inside is the endometrium, and that is the lining of the uterus. And so that's the root of the word endometriosis, which is when the lining of the uterus gets outside of the uterus in places where it isn't supposed to be, and wreaks havoc and pain. And there's a whole ball of wax around endometriosis care, but it affects the quality of lives of so many women. And so this is the uterus. You've got your myometrium, you've got your endometrium. So the cervix comes down and just protrudes into the vagina like that, and there's a little canal that goes up. This is lined with glandular cells that the doctor samples when you go to get your pap smear done. And then it turns to endometrium, which is an active glandular lining that responds to your hormones and gets thick as your menstrual cycle progresses and ready for a pregnancy. When the pregnancy doesn't happen, the lining sheds and the whole process repeats. So this is typically what a normal top of a uterus looks like. So you'll see the cavity opens up into a very narrow canal that goes through the muscle of the uterus and out into the fallopian tube. Now, I made my fallopian tubes really short. They're sometimes very long and convoluted, but they tend to have narrow spots and wider spots. I imagine the egg going through there like a caver going through a tight cave and trying not to get stuck. So this is where ectopic pregnancies can happen. If there's a little tightening in the tube or there's a bit of scar tissue, the pregnancy can get trapped here and the egg gets fertilized in the tube. And then you have an ectopic pregnancy, which is life-threatening. So the tube comes down with the little fimbria, which are way more complex than my ugly drawing, and sort of goes around or near the ovary. So here are your ovaries. Now, your ovaries are sort of attached to the uterus by a suspensory ligament that has a little bit of blood flow in it, but most of the blood supply to the ovaries comes from the lateral pelvic wall, okay? And that's going to be important when I talk about hysterectomy. So, what happens is one of your ovaries will ovulate, and they don't take turns, you can't predict, but one of them will ovulate. Generally, the egg will get swept up into the fallopian tube. It's usually fertilized in the tube and then makes its way down into the uterus. Okay? And then, that's a vagina. Ha, isn't that hilarious? Okay, and so this is your cervix front on. So when we put a speculum in to go to do a pap smear, your cervix looks like a little donut with a dimple in the middle. And in that little dimple, that's the canal up into here. So they put the little brush up there, get some of those cells. So what we're trying to get is the gland cells from up in the canal and the squamous cells from the surface of the cervix. And these cells are in constant turnover. And so when cells are very active that way, they're susceptible to malignant change. And with cervixes, there's usually a pre-cancerous phase. So that's the pap smear. We'll sample this part of the cervix. A pap smear does not test for STDs, nor does it sample the lining of the uterus itself. So it isn't generally a screening for endometrial cancers, only changes on the cervix itself, okay? But that's what your cervix looks like. So when women have a hysterectomy, there's confusion around a total hysterectomy and whether or not that means the ovaries were removed. The language around hysterectomy has absolutely nothing to do with the ovaries. So a total hysterectomy is the removal of the uterus and the cervix. Years ago, we did subtotal hysterectomies where you basically chopped the uterus off above the cervix and left the stump of the cervix. And I guess it was maybe thought to be important in sexual function. There's not been a lot of evidence around that one way or the other, and I've never had a woman tell me that losing her cervix ruined her sex life. But having said that, I don't think we really know the full answer. What we do know is if you leave the cervix behind and later there's a cervical cancer, removal of that cervix becomes very, very challenging. So that's one of the reasons we went from subtotal to total hysterectomy. Plus, a little bit of this lining can be at the top of the cervix you leave behind. So some of these women get little light spotty periods every month from that lining getting stimulated. So most hysterectomies are total, meaning the entire uterus and cervix is removed. Now, since 2010 maybe, the recommendation has been if you have your uterus out, your tubes should go as well. And the reason being, we now understand that a significant amount of ovarian cancer actually begins in the fallopian tubes. And because ovarian cancer is not easy to diagnose early and tends to have a poor prognosis, prevention up until recognizing this about tubules wasn't really possible. And so we do tend to recommend removing the tube. So if you're having a hysterectomy, say you're in your late 30s, early 40s, and your periods are terrible, and we're going to do a hysterectomy, you will have a hysterectomy with bilateral salpingectomy, which is removal of the uterus and cervix and the fallopian tubes. Now, the fallopian tubes are just attached to the, with very filmy tissue. So basically we just lift the tube and you cauterize underneath it and the tube comes out. If you're having your ovaries left in, this is where we transect. So this little attachment of the ovary to the uterus gets divided and the ovary is attached laterally, so it just basically stays there. Sometimes they will flop down and attach down in the pelvis, and there are some potential issues that can happen with that, but that's not common. So most of the time, the blood flow to the ovary doesn't get disrupted and your hormones are unchanged after a hysterectomy. Having said that, it's really difficult to know because there's such a wide variation in the age of menopause. But it could be that in women whose ovaries are already undergoing atresia and they're in perimenopause, after hysterectomy, I do see sometimes that their symptoms get worse. And, whether that would have happened with or without the hysterectomy is very difficult to say. If the ovaries are coming out with the uterus, then the attachments out here are divided and the ovary comes out with the uterus. So you could remove one ovary and leave the other, for example. And usually when we get the cervix, it's right underneath the cervix so that the vaginal length is preserved. And instead of your vagina ending in a cervix, it just ends. So it's kind of like it's a pouch, but it was before. It just had a little fibrous knob at the top with a itty bitty little opening in it. So it really is essentially unchanged in terms of vaginal depth and stuff. Now that can change when we do vaginal repairs for prolapse, but that's a whole other thing. So generally speaking, that's what happens when you have a hysterectomy. Now, what are the consequences of removing these things? Well, as you'll hear in a minute, menopause is a really slow progression of decreasing frequency of ovulation and falling and erratic hormone levels. And so that occurs over a period of 5 to 10 years. So for women who have their ovaries removed prior to the onset of menopause, it's basically like they go through that transition in a day or two. The abrupt withdrawal of reproductive hormones is usually a staggering blow to quality of life. And those women really need hormone replacement therapy. So the difficulty can rest when you need to remove the ovaries in a young woman who cannot take HRT. And there are some alternatives that can help, but that's often a desperate situation. And there are women who feel like, take them out because I don't want ovarian cancer and I don't need them. Here's the shit. Yes, getting a diagnosis of ovarian cancer when you don't have ovaries is rare, but it isn't impossible because a cancer that starts in the lining of the abdomen looks and acts exactly like ovarian cancer. And if we believe that the majority of ovarian cancer might occur in the fallopian tubes, removing the tubes will reduce your risk. And that, as far as we know, has no consequence to you hormonally or otherwise. But removing the ovary does have consequences. So pre-menopause, the consequences are disastrous. During the perimenopausal transition, it will usually exacerbate symptoms significantly. But however, even women who have been through menopause, there may be consequences to removing the ovaries. Um, it's not a guarantee, but even after menopause, the ovaries do make androstenedione from the ovarian stroma. So they're no longer producing eggs, but they do make precursors to estrogen and testosterone. So there are some women who have their ovaries out who completely lose their sexual drive and their ability to respond sexually. And hormone replacement therapy doesn't always address that. So these are important discussions to be having when you're debating whether or not to leave or retain the ovaries. And I usually tell women, we don't have a crystal ball. No one can predict. If we leave it in and you get a big old cyst in a year and have to have more surgery, you might say, should have had it out. The thing is, you can get your ovaries out, you can't put them back. And so it's a decision that might have some consequences on your quality of life. So that's a little primer on that. And, if you're considering hysterectomy or you've had one, it might give you some cause for reflection, or maybe generate some questions for your care provider. So this is 21 minutes. I'm going to pause now, regroup, and then I'm going to come back and we're going to talk about the hormone cycle. Okay, stay tuned.